Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Gilead Sciences, Inc.
Dear friends, dear colleagues, hello, my name is Javier Cortés. I'm a breast cancer medical oncologist working in both cities, Madrid and Barcelona in Spain. Welcome to this segment titled Setting the Stage in First-Line Management of Metastatic Triple-Negative Breast Cancer. As you all know, metastatic triple-negative breast cancer is a clear and critical unmet need. Patients with this disease who initiated first-line treatment, at least in the United States, and this data comes from the real-world evidence, show that about 50% or lower can start second line, and only in the range of 1 out of 4, 25 to 26% of patients will be able to receive third line or beyond. Over the last year, the median overall survival has changed very little. The median overall survival has been established in the range of a year, year and a half, maybe 2 years for a subgroup of patients. And maybe this curve has been slightly superior over the last years, with introduction of more effective drugs, also the introduction of PARP inhibitors in the small number of patients with germline BRCA1 and or BRCA2 mutations. And of course, with introduction of immune checkpoint inhibitors for those patients whose tumors do have PD-1 expression, and with introduction of the antibody-drug conjugates in second line or beyond. Nevertheless, the median overall survival, as I said before, ranges from a year to a max of 16, 17, 24 months, more with the PD-1 positive tumors than with the PD-1 negative, and clearly worse survival compared with other tumor types such as HER2 positive or ER positive, HER2 negative disease. So we need clearly more and better agents in the first-line setting to try to optimize how patients will behave before disease progression, and to try to have more patients who will be able to receive second-line therapy beyond progression. This is the clear unmet need we have in the field of metastatic breast cancer. In the next segment, Dr. Ana Garrido from Dana-Farber will focus on studies evaluating antibody-drug conjugate-based combinations in the front-line setting. We will discuss in detail, for example, the ASCENT-04, trastuzumab govitecan plus pembrolizumab, for patients whose tumors do have PD-1 positive tumors. Then, in segment 3, I will discuss studies evaluating monotherapy antibody-drug conjugates in the upfront setting. Later, in segment 4, Dr. Sarah Harwich will highlight ongoing studies for TNBC in both the adjuvant and or the neoadjuvant setting. Beautiful data will be there in a few months or years. Finally, I will join you again in segment 5 to provide some clinical pearls from this program. Once again, thanks very much for joining us. I'm very happy to discuss with you the next segments.
Welcome to this segment titled Enhanced Therapeutic Optimization with ADC-Based Combination Approaches in the Frontline Setting. My name is Ana Garrido Castro, and I'm a breast medical oncologist at Dana-Farber Cancer Institute in Boston, Massachusetts. So today we're going to talk about some of the key studies in the frontline setting for patients with metastatic triple-negative breast cancer and how these might impact clinical practice. With the improvements with TROP2-directed antibody-drug conjugates in the pretreated metastatic TNBC setting, came a lot of interest in looking at combinations of these agents with immune checkpoint inhibitors in earlier line settings, such as PD-L1 positive metastatic TNBC, and potentially also in other settings. We know that the TROP2-directed topo-1 inhibitor antibody-drug conjugates can engage with immune effector cells to elicit anti-tumor immunity through different mechanisms, including antibody-dependent cell cytotoxicity or complement-dependent cytotoxicity. In addition, the topoisomerase 1 inhibitor payload of these antibody-drug conjugates can induce activation of the cGAS STING pathway, which in turn can stimulate T cell recruitment into the tumor. So, with this comes the hypothesis that perhaps the topo-1 inhibitor induced DNA damage can activate this STING pathway and synergize with immune checkpoint inhibitors. There have now been several clinical trials launched looking at the combination of TROP2-directed topoisomerase 1 inhibitor antibody-drug conjugates with immune checkpoint inhibitors in patients with metastatic triple-negative breast cancer. Specifically, in PD-L1 positive metastatic TNBC, where the current standard approach has been chemotherapy in combination with pembrolizumab, the PD-1 inhibitor, there have been 2 phase 3 trials looking at combinations of TROP2-directed ADCs plus immune checkpoint inhibitor. From these, we've seen the results of the first study that was reported at ASCO 2025. ASCENT-04, or Keynote D19, was a randomized phase 3 trial for patients with previously untreated, locally advanced, unresectable, or metastatic triple-negative breast cancer that was PD-L1 positive, defined by a combined positive score greater than or equal than 10 using the 22C3 assay. Patients who enrolled in this study had to have a disease-free interval of at least 6 months since treatment in the curative setting, and no prior therapy with immune checkpoint inhibitors was allowed. Patients were randomized 1-to-1 to receive the combination of sacituzumab govitecan plus pembrolizumab, or the standard chemotherapy of physician's choice, either a taxane, paclitaxel, or nab-paclitaxel, or doublet chemotherapy with carboplatin plus gemcitabine, in combination with pembrolizumab. Importantly, patients who were randomized to the control arm of chemotherapy of physician's choice plus pembrolizumab were offered the option to cross over to receive second-line sacituzumab govitecan at the time of progression. The primary endpoint of this study was progression-free survival, and overall survival remained a key secondary endpoint. A total of 443 patients were enrolled on this study. Approximately 1/3 of patients were enrolled in the US, Canada, and Western Europe, and approximately 1/3 presented with de novo metastatic triple-negative breast cancer. Almost 20% of patients had a disease-free interval of 6 to 12 months from treatment in the curative setting. Importantly, the chemotherapy distribution that was selected prior to randomization was distributed relatively similarly between taxane and carboplatin plus gemcitabine at about 50% each. The study met its primary endpoint of progression-free survival, demonstrating a significant improvement in median PFS with the combination of SG plus pembrolizumab versus chemotherapy plus pembrolizumab. The median PFS with SG plus pembrolizumab was 11.2 months, compared to 7.8 months with chemotherapy plus pembrolizumab, corresponding to a hazard ratio of 0.65 that was statistically significant. Across the pre-specified subgroups, the PFS benefit appeared to be relatively consistent. For overall survival, the data remained immature at the time of the initial report of results, with a maturity of about 26% of events. There did appear to be a positive trend favoring sacituzumab plus pembrolizumab versus chemotherapy plus pembrolizumab, but these data remain immature and additional follow-up is needed. Importantly, just over 80% of patients in the control arm who went on to receive any subsequent treatment after discontinuation of chemotherapy plus pembrolizumab received sacituzumab govitecan as second-line therapy. The median duration of response was prolonged with SG plus pembrolizumab, reaching 16.5 months compared to 9.2 months with chemotherapy plus pembrolizumab. Overall, the safety profile of the combination of SG plus pembrolizumab was consistent with the known profiles of each agent. Some of the most common adverse events that were seen in the experimental arm were neutropenia, fatigue, and GI toxicities such as nausea or diarrhea, in addition to alopecia. Importantly, 47% of patients in the combination arm of SG plus pembrolizumab experienced grade 3 or higher neutropenia, highlighting the importance of utilization of growth factor support, particularly in those patients at increased risk of febrile neutropenia. In terms of adverse events of special interest that were reported on the study with pembrolizumab, there were endocrine-related events reported, although these did appear to occur at a relatively low frequency, with 2% of patients experiencing any grade hypothyroidism, 1% any grade hyperthyroidism, among others. So overall, the adverse events of special interest were consistent with the known safety profiles of each agent, and there were no new safety concerns observed or increased rates when combining SG plus the immune checkpoint inhibitor. In summary, ASCENT-04 demonstrated that the combination of SG plus pembrolizumab significantly improves median progression-free survival compared to chemotherapy plus pembrolizumab. The overall survival data remain immature. The NCCN guidelines were recently updated to now reflect SG plus pembrolizumab as a Category 1 preferred regimen for patients with PD-L1 positive metastatic triple-negative breast cancer. In addition to ASCENT-04, there are other trials that are exploring combination of TROP2-directed ADCs with immune checkpoint inhibitors in first-line PD-L1 positive metastatic TNBC, including the TROPION-Breast05 study. This is also a randomized phase 3 trial for patients with previously untreated, inoperable, locally advanced or metastatic TNBC who have PD-L1 positive tumors per central confirmation. Patients in TROPION-Breast05 are randomized to receive Dato-DXd plus durvalumab or Dato-DXd alone, or chemotherapy of physician's choice in combination with pembrolizumab, and results from this trial are awaited. Now, with some of the initial results from the phase 1 Begonia trial exploring combination of topo-1 inhibitor antibody-drug conjugate plus immune checkpoint inhibitor in the first-line setting, there were some initial results showing that there was anti-tumor activity observed with the combination of these agents in patients with PD-L1 positive, but also PD-L1 negative metastatic triple-negative breast cancer. And so this begs the question of perhaps given these potential immunomodulatory effects of the topo-1 inhibitor ADC, could there be synergy between the TROP2 antibody-drug conjugates with immune checkpoint inhibitors, even in more immune cold settings, such as PD-L1 negative metastatic TNBC? And there are several clinical trials that are exploring combination of TROP2-directed antibody-drug conjugates with immune checkpoint inhibitors in PD-L1 negative first-line metastatic TNBC. SASAO TNBC is an investigator-initiated randomized phase 2 trial for patients with previously untreated metastatic triple-negative breast cancer, that is PD-L1 negative per local testing, who have not received prior immune checkpoint inhibition, who are randomized to receive either SG plus pembrolizumab or SG alone in that first-line setting. TROPHEUS-11 is a randomized phase 3 trial evaluating sacituzumab tiromatecan, another TROP2-directed antibody-drug conjugate that carries a topoisomerase 1 inhibitor payload, with or without pembrolizumab versus chemotherapy of physician's choice in patients with PD-L1 negative metastatic TNBC. And finally, the DIAMOND study is a phase 2 investigator-initiated trial exploring the combination of Dato-DXd plus durvalumab versus Dato-DXd alone, again in patients with PD-L1 negative metastatic triple-negative breast cancer who have not received prior therapy in the advanced setting. So with these clinical trials and the emerging data for combinations of TROP2-directed ADCs plus immune checkpoint inhibitors, there is much more to come in the field of metastatic TNBC. And these combinations are also being explored for patients with early-stage triple-negative breast cancer as neoadjuvant therapy, and also as adjuvant therapy in those patients who are at higher risk of recurrence who have residual disease after preoperative therapy. There are also new agents looking at new payloads in combination with immune checkpoint inhibitors, new targets for ADCs that are being explored, bispecific antibody-drug conjugates as well that are being evaluated. And so we eagerly await the results of these trials as we look at the new wave of antibody-drug conjugates and combinations that may make its way into the treatment landscape for patients with triple-negative breast cancer. I'd like to thank you for participating in this activity, and please continue to the next segment where you will hear Dr. Javier Cortes discuss recent clinical data related to the use of monotherapy ADCs in the upfront setting in patients who are not candidates for treatment with PD-1 or PD-L1 inhibitors.
Dear friends and colleagues, welcome to this segment titled The Role of Monotherapy Antibody-Drug Conjugates in the Upfront Setting. My name is Javier Cortes, breast cancer medical oncologist working in both cities, Madrid and Barcelona in Spain. In this segment, I will discuss recent clinical data related to the use of monotherapy antibody-drug conjugates in the upfront setting in patients who are not candidates for treatment with immune checkpoint inhibitors. Unfortunately, metastatic triple-negative breast cancer is an unmet need. And this is even more clear for those patients who are not candidates for immune checkpoint inhibitors. There are different reasons for that. The most important one is when the tumors do not express PD-L1. But there are other reasons for patients not to be candidate to immune checkpoint inhibitors. For example, we do not have data what happened for those patients who received either pembrolizumab, atezolizumab, or whatever the immune checkpoint inhibitor is in the early breast cancer setting, and they experience progressive disease afterwards. Should we revisit the role of these drugs or not? And third, what happened with those patients with important, significant comorbidities that might exclude the treatment with these drugs? So there is a significant number of patients that will be unable to receive immune checkpoint inhibitors. And we need to treat these patients. And today the standard of care is chemotherapy. The paclitaxel, nab-paclitaxel, carbogem. How can we do it better? We knew from the ASCENT study that sacituzumab govitecan improved progression-free survival and overall survival compared with chemotherapy. Is sacituzumab superior to chemotherapy in the front line for those patients who will not receive immune checkpoint inhibitors? This is basically the ASCENT-03 study. Chemotherapy, either pacli, nab-pacli, or carbogem, compared with sacituzumab govitecan. Patients were randomized in a 1-to-1, and progression-free survival by BICRA was the primary endpoint. Patients could have received treatment in the early breast cancer, but at least 6 months of treatment-free interval was needed. Very interestingly, patients who received the chemotherapy and experienced progressive disease according to BICR were able to receive SG. This is a very, very interesting aspect to be clearly considered. The primary endpoint was positive in favor of SG. Hazard ratio was 0.62. Those patients who received SG, it have a median progression-free survival of 9.7 months, compared with 6.9 months with chemotherapy. Very similar features when this analysis was conducted by the investigator assessment. Hazard ratio 0.64 and very similar progression-free survival numbers. When we looked at the subgroup analysis of PFS by BICR, we couldn't observe any subgroup of patients who did not benefit or clearly benefited more compared with the other ones. So at the time being, all patients benefited with SG compared with chemotherapy. Overall response rate was similar, 46% with chemo compared with 48% with SG, but the duration of response was significantly higher with SG compared with chemo. 12.2 months with SG, 7.2 months with chemotherapy, median duration of response. Overall survival was very immature at the time this analysis was conducted. Nevertheless, the hazard ratio was 0.98. We looked at the progression-free survival 2, PFS2. The median PFS2 was 14 months with chemotherapy and 18.2 months with SG, which maybe might reflect in some way how the overall survival will behave. In terms of safety, nothing unexpected. Grade 3 or higher treatment emergent adverse events and treatment emergent serious adverse events was similar between SG and chemotherapy, but treatment emergent adverse events which led to the treatment discontinuation was higher, 12% with chemotherapy compared with 4% with SG. The most important adverse events, as expected, were neutropenia and gastrointestinal events, including diarrhea, 9% grade 3 or higher. So in conclusion, SG led to a statistically significant and a clinically meaningful improvement in progression-free survival compared with chemotherapy. The duration of response and PFS2 was also superior with SG compared with chemotherapy. Nothing unexpected in terms of adverse events, but very important to remind us the use of G-CSF growth factors for those patients who are on risk to have neutropenia. There is another study, which is TROPION-Breast02, with a similar trial design, which basically compared Dato-DXd compared with chemotherapy. Three key differences. The first one, investigator chemotherapy did not include doublets, only single agents, paclitaxel, nab-paclitaxel, CAPE, eribulin, or carboplatin. No carbogem was allowed. Second important aspect here is that patients who received treatment in the early breast cancer were able to be included regardless the treatment-free interval. Moreover, 15% of patients were included with a treatment-free interval of less than 6 months and 5% with a treatment-free interval between 6 to 12 months. And this important aspect is that the primary endpoint was dual, overall survival and progression-free survival by BICR. Obviously, crossover was not allowed. TDSD is not approved in the second-line setting. PFS was also superior with Dato-DXd compared with chemotherapy. Hazard ratio 0.57, the median PFS moved from 5.6 months to 10.8 months. The median PFS here with chemotherapy was inferior. We should not forget that some patients were included in the very early relapse, less than 6 months. Again, PFS by investigator was also superior with Dato compared with physician's choice. What about overall survival? Overall survival was superior with datopotamab compared with chemotherapy with a nice hazard ratio, 0.79, and the median overall survival ranged from 18.7 months to 23.7 months with datopotamab deruxtecan. Again, crossover was not allowed. When we analyzed the subgroup analysis for survival, we observed that in those patients who were treated in Western countries where SG is approved, the hazard ratio crossed the 1. Duration of response was also superior with Dato compared with chemotherapy, 12.3 months compared with 7.1 months. Dato compared with chemotherapy, basically identical benefit compared with the ASCENT CO3 data. Overall response rate was superior here, roughly 30% with chemotherapy, more than 62% with Dato-DXd. What about the safety? I think that any grade of toxicity and grade 3 or superior was similar between Dato and chemotherapy, but there were some important adverse events that are quite new for a new drug. We should not forget the eye disorders with Dato-DXd and also stomatitis. So based on all this data, I think that TROPION-Breast02 met both dual primary endpoints, PFS and survival, and safety was manageable and consistent with the known profile of this drug. So how do these data compare one with the other? How to compare ASCENT-03 and TROPION-Breast-02? I think that that's something that we shouldn't do it, but it's obvious that we are ready to compare. Just some thoughts for us to think about. Inclusion criteria were different. 0.5% of patients did have PD-1 positive tumors in the ASCENT-03, compared with 10% in TROPION-Breast-02, 20 times higher. This treatment-free interval was shorter for some patients in TROPION-Breast-02, 15% with less than 6 months. None of these patients were included in the ASCENT-03. Also, the doublet of chemotherapy, Carbogem, in 45% of patients in the ASCENT-03, no patients in TROPION-Breast-02. And of course, the crossover that might affect the overall survival results. When we looked at the 12-month overall survival rate, was identical, 75% in the ASCENT-03, 75% in the TROPION-Breast-02. So I think that the key message that I would like to make here is that if we have a patient tomorrow with metastatic triple-negative breast cancer who does not qualify for immune checkpoint inhibitors, we have now two clear drugs. We have sacituzumab govitecan, we have etopostamab deruxtecan, which have improved progression-free survival. We should not forget that about 50% of these patients will be unable to receive a second line. So I think that we have changed, that's my opinion, the standard of care. According to the NCCN guidelines today, sacituzumab govitecan has qualified for category 1, the etopostamab category 2A. So both drugs have shown important improvements in progression-free survival. Both drugs should be considered as preferred options. Afterwards, we should discuss with our patients about toxicity, neutropenia, diarrhea with SASI, maybe stomatitis and eye disorders with DATO. I think that we have to change the standard of care. We have to include these drugs in the future of the treatment of metastatic triple-negative breast cancer if clearly this patient will not qualify for immune checkpoint inhibitors. Just to conclude, other ongoing clinical trials are there. Other anti-Trop2 antibody-drug conjugate, SAC-TMT, is also being explored in the first-line setting. Also, different combinations of ADCs plus immune checkpoint inhibitors are being explored in the PD-1 negative population. So maybe in the future, we'll have not only SG and Dato-DXd, but also other drugs and other strategies that may be approved in this setting. Dear friends, dear colleagues, thank you very much for participating in this activity. And please continue to the next segment, where you will hear Dr. Sarah Harvich discuss ongoing studies in the adjuvant and in the neoadjuvant setting for triple-negative breast cancer patients.
Welcome to this segment titled Advancing Adjuvant Care Patterns in Triple-Negative Breast Cancer. I'm Dr. Sarah Hurvitz. I'm a professor of medicine and the Smith Family Endowed Chair in Women's Health and head of the Division of Hematology Oncology at the Fred Hutch Cancer Center, University of Washington in Seattle, Washington. Today, I will discuss ongoing studies in the curative setting, namely the neoadjuvant setting, as well as the post-neoadjuvant setting, patients being treated after receiving neoadjuvant therapy. And I'll discuss how these studies might in the future impact clinical practice. The first studies that I'll go over are those studies conducted after a patient has received neoadjuvant therapy and has completed surgery and has been found to have high-risk disease. The first of the studies that I'll discuss is the ASCENT-05 clinical trial. This is a study evaluating 8 cycles of sacituzumab govitecan combined with pembrolizumab compared to treatment of physician's choice, which is either pembrolizumab or pembrolizumab combined with capecitabine, as adjuvant treatment for patients who have stage 1 to 3 triple-negative breast cancer with an estrogen receptor expression of up to 10%. with residual disease after completing their chemotherapy, surgery, and radiation therapy. This study will evaluate whether the antibody drug conjugate sacituzumab govitecan combined with pembrolizumab improves outcomes for patients with this particularly high risk disease. Another study is the Tropion-Breast03 clinical trial. In this study, patients are randomly assigned to receive datopotamab deruxtecan for 8 cycles, either alone or in combination with durvalumab, versus standard of care, which is either capecitabine or pembrolizumab, or capecitabine with pembrolizumab as adjuvant therapy. Patients are allowed on if they had stage 1 to 3 triple negative breast cancer with residual invasive breast cancer at the time of surgery after receiving neoadjuvant treatment. A third post neoadjuvant clinical trial that I'll talk about is the SASIA phase 3 clinical trial. In this study, patients are treated with sacituzumab govitecan for 8 cycles or treatment of physician's choice of capecitabine or platinum for 8 cycles or observation. Patients have to be post neoadjuvant after receiving taxane based chemotherapy. And this study not only allows triple negative breast cancer, but any HER2 negative breast cancer, including hormone receptor positive disease. For patients with triple negative breast cancer, any residual invasive disease is allowed at the time of surgery. But for hormone receptor positive disease, patients have to be found to be at particularly high risk, either by nodal involvement or having a high CPS EG score. The fourth post neoadjuvant clinical trial is the TroFuse 12 study. This study is a phase 3 trial that is being done in patients who've had triple negative breast cancer and treated with neoadjuvant therapy and found to have residual disease at the time of surgery. Patients are randomly assigned to receive sacituzumab tiromatecan with pembrolizumab or treatment of physician's choice, which includes either pembrolizumab or pembrolizumab plus capecitabine. Those are the four post neoadjuvant studies that I wanted to review with you, all of them looking at slightly different patient populations and different post neoadjuvant treatment regimens. There are also 2 neoadjuvant studies that I would review, and that includes Tropion Breast 04. This is a neoadjuvant phase 3 clinical trial being conducted in patients who have stage 2 or 3 triple negative breast cancer or hormone receptor low HER2 negative breast cancer. The definition of hormone receptor low is a hormone receptor of 1 to 9%. Patients are randomly assigned to receive datopotamab deruxtecan with durvalumab for 8 cycles in the neoadjuvant setting, followed by 9 cycles of durvalumab with or without chemotherapy in the adjuvant setting, versus pembrolizumab plus chemotherapy for 8 cycles in the neoadjuvant setting, followed by 9 cycles of standard of care pembrolizumab with or without chemotherapy. The TroFuse 32 study is the second neoadjuvant study that is looking at triple negative or hormone receptor low, up to 10% hormone receptor expression, breast cancer. This is a neoadjuvant study that's phase 3, and it is evaluating sacituzumab tiromatecan with pembrolizumab, followed by carboplatin paclitaxel pembrolizumab versus the typical Keynote 522 regimen, which is pembrolizumab in combination with carboplatin, paclitaxel, followed by anthracycline-based therapy. Patients are allowed in that study if they have T1C node positive disease or T2 disease that has up to N2 positive lymph nodes. These studies are all likely to have an impact on whether or not we are using antibody drug conjugates in the curative setting, many of them in combination with immune checkpoint inhibitors. In the next 3 to 5 years, we may have new data that leads us to be able to use one of these agents in the curative setting. So, thank you very much for participating in this activity. Please continue to the next segment where you will hear Dr. Javier Cortez provide an educational clinical pearls summary of all the segments in this program. Thank you.
Dear friends, dear colleagues, welcome to this segment titled Antibody-Drug Conjugates in Triple-Negative Breast Cancer, Clinical Pearls. My name is Javier Cortez. I'm a breast cancer medical oncologist working in both cities, Madrid and Barcelona, in Spain. We have seen many good news when we improve outcomes for patients with metastatic triple-negative breast cancer. I think it's good news. But nevertheless, unfortunately, this disease continues to be an unmet need. We have seen the poor overall survival data we have, the poor progression-free survival data we have, and how patients who progress on treatment with antibody conjugates in the first-line setting, many of them will receive second-line therapy. And of course, just a few will receive third-line therapy or beyond. So we need to optimize the strategies. We need to incorporate antibody conjugates in the first-line setting. We have seen that if we have patients with tumors who do have PD-L1 expression, the combination of SG plus pembrolizumab clearly improves progression-free survival compared with chemotherapy and pembrolizumab. And this is, from the scientific perspective, the clear standard of care. And I would like to say something similar for patients who do not qualify for immune checkpoint inhibitors. We have seen ASCENT-03 and TROPION-Breast02 showing how this antibody conjugate, SG, and datopotamab deruxtecan respectively, improve progression-free survival. Also, we have seen that when the crossover is not allowed, overall survival is also observed with these drugs, which clearly suggests that either SG or Dato-DXd should be used, if possible, in the first-line setting. Other drugs and other strategies are also upcoming here, sac-TMT, or combinations of antibody conjugates plus immune checkpoint inhibitors will play a significant role here, hopefully. And we'll see this data in the upcoming months or years. But we also have learned how these drugs are being implemented in the early breast cancer setting. We have discussing how these drugs will hopefully improve pathological complete remission when added into the neoadjuvant space. How these drugs will optimize long-term outcomes for those patients who do not achieve pathological complete remission compared with chemotherapy today, with capecitabine maybe, or even with pembrolizumab. So these drugs, we hope that in the very next future, will be able not only to improve long-term outcomes, but also to cure more patients. Dear friends, dear colleagues, we are all together here to optimize our patients' lives. We need to be all together. We need to enroll patients in clinical trials. We need more and better drugs. We need the regulatory agencies to have these drugs as soon as possible into the clinical practice. I think that we all together will be able to continue optimizing our patient journey. We should not forget that the majority of these patients continue to die as a consequence of the disease. Thank you very much, dear friends, dear colleagues, for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Stay well.